everybody, my name is Carly Bands and today I will be presenting Topic A. Topic A gives us John. He's a 58-year-old male that presents with a 6-month history of right knee pain and a new onset of right hip pain. He has a BMI of 32. His knee pain worsens with activity and improves with rest, and he reports stiffening lasting less than 30 minutes in the morning and difficulty climbing stairs and getting in and out of his chair. His clinical findings show on physical exam a knee with crepitus, mild swelling, and decreased range of motion, a hip that has pain with internal rotation and flexion, and limited range of motion. His labs show a normal ESR and CRP, and imaging shows a knee with joint space narrowing and osteophyte formation, and a hip with loss of joint space, subchondral sclerosis, and osteophytes. So with this in mind, the diagnosis that I would give this patient is osteoarthritis. Osteoarthritis is the progressive loss of articular cartilage, and this can be differentiated between rheumatoid arthritis because rheumatoid arthritis is symmetric for the patient, but osteoarthritis is not symmetric, as we see as this patient is only dealing with problems on his right side. So now that we know the diagnosis, we can go on to anatomy and physiology. Articular cartilage covers the pad of articulating bony surfaces that reduces friction between those two bones. When we look specifically at the hip, we see that the head of the femur fits in the pelvis and has articular capsule with synovial layer and bursa. The hip can flex, extend, abduct, adduct, laterally rotate, and medially rotate, and this is all supported by a large group of muscles that help with every one of these range of motions. When we look specifically at the knee, we see that there are several ligaments for stabilization, including the ACL, the PCL, and the meniscus. The knee is also covered by a patella bone. It has a quadricep tendon to strengthen and stabilize, and the knee joint connects the femur and the tibia. We also see flexion and extension when we have a knee that is working correctly. Okay, so now that we know the anatomy and physiology, we can move to our pathophysiology. And this starts when chondrocytes of the articular cartilage are damaged. This damage causes injury to chondrocytes that impacts function of extracellular matrix. And this is important because the extracellular matrix is synthesized by chondrocytes. We also find that we have thickening of subchondral bone that is from altered mineralization of collagen, and we have hypertrophy of synovial linings. All of this leads to innate and adaptive immune responses that are triggered by DAMPs, and DAMPs are those damage-associated molecular patterns. So, innate and adaptive immunity, we have an influx of cytokines, tumor necrosis factor, prostaglandins, and nitric oxide. So you can imagine all the inflammation, pain, swelling, and limited range of motion caused by this. So when we diagnose this patient, we can observe their bones through x-ray, and we also look for 5 patterns in their physical exam and history. We are looking for pain that increases with activity and eases with rest, a patient that is greater than 45 years old, a patient that has greater than 30 minutes of stiffness in the morning, joint enlargement, and limited range of motion. So with our patient specifically, we have a knee that shows crepitus, swelling, and decreased range of motion. He is greater than 45 years old. We have a hip that shows pain with rotation and decreased range of motion. And we also have osteophytes, and osteophytes are bony outgrowths on these bones that are associated in this joint area. So for this patient in particular, the treatment that we would look for is first weight reduction and exercise. This is kind of our staple in preventing and treating osteoarthritis. It increases your muscle tone, increases your range of motion, improves balance, decreases inflammation, and decreases stress on joints, and decreases damage of articular cartilage. So the less pressure and stress that you have on those joints, the less damage you'll have to that articular cartilage and the less breakdown you'll have of that articular cartilage. For this patient, we could also suggest NSAIDs at appropriate intervals to help decrease inflammation. Steroids might be helpful for this patient, but it's not our first treatment option. And if all else fails, we can go to surgery, specifically knee arthroplasty.